It's been over 35 years since Ghana recorded the first HIV/AIDS case. Many infected persons succumbed to the virus and died. The increasing number of deaths recorded at the time was partly due to the inadequate knowledge on how the deadly virus could be managed. With time, scientists across the globe made strenuous efforts in researching into the HIV/AIDS virus and came up with medications and therapies to prolong the lifespan of persons living with HIV. Aside from the medications and the numerous therapies, advocacy campaigns were introduced to create awareness about the virus and to educate infected persons on ways of reducing the spread. The advocacy helped in the containment of the disease, and from all indications, however, the education on HIV/AIDS and its associated illnesses over the years had slowed down for some time, leading to a surge in new cases in recent times.
AIDS be real, but you sabi the deal. The last girl where you drop will be your last meal.
We tell them AIDS a dangerous disease. I'm on advising AIDS on this surface.
HIV patients are faced with numerous opportunistic diseases which are unknown. Patients have to manage taking antiretroviral drugs to suppress the virus. They also take additional pills to treat the many diseases associated with the virus. One such disease is hypertension in persons living with HIV. With prolonged survival and aging of persons with HIV and undergoing antiretroviral therapy, hypertension has emerged as a significant cause of increased infections and deaths worldwide. People living with HIV are at an increased risk for hypertension than HIV uninfected individuals. In patients with HIV, hypertension has been shown to be associated with an increased risk for hospitalization and adverse diseases. However, little is known about the dangers of this comorbidity among patients living with HIV in Ghana. In this documentary, I aimed to find out the prevalence rate, factors associated with hypertension among HIV-infected patients, and treatment regimens available. Meet Madam Charity Owusu-Danso, an HIV patient living with hypertension in Ghana. Charity is a 46-year-old woman who has successfully managed her HIV condition for the past 20 years and still counting. She was diagnosed HIV positive in 2002. She revealed that her late husband infected her with the virus, and since then she has been surviving through pills. She narrates her ordeal.
My late husband started falling ill, and he's that kind of person who will not go to hospital when he's not well. But this time it was so bad that he himself agreed to go. So we drove all the way from where we were, somewhere in the central region, and then we came to Ridge Hospital. Then he was admitted for 2 weeks. And the doctors were actually trying so many things, and they couldn't even give a proper diagnosis. So within 2 weeks, he passed away. We buried him, we did everything. I went back to my family, and then few months later, I also started falling ill. So over there, I was left alone with my children and my family. I really don't know what was wrong with me, but it clicked my mind, come back to Rage to find out what killed my late husband, because I knew that the nurse told them that they should bring me, and then my in-law also said HIV, so I have to put things together to know what is also wrong with me.
After unraveling the truth of her HIV status through personal investigations, Charity thought her world has come to an end. Self-deprivation, hostility, abstention, pain, rage, and the fear of the unknown became her daily predicament.
I became angry, and then I started denying myself, and I even got angry with my children, the children I had with him. But then I realized that it won't help me. During the test, they took me through the pre-counseling, so I was told that I can live for a little longer if I take measures and I take good care of myself. So then I said, okay, I have to live and accept that I have become positive. The little that I can do to support my children, I have to do it.
After going through therapy, she decided to give life a chance since HIV can be managed. Charity is now a shining star and a life coach to other persons living with the virus. All was well until other diseases like hypertension creeped in at age 38. At the time, she was heavily pregnant with her 5th child. This mother of 6 shares how she has survived dealing with HIV and hypertension at the same time.
During my 5th pregnancy, yes, that was where the whole thing started. It got to a point that I was diagnosed a pre-eclampsia patient, so I have to premature give birth that stage. So that was the stage that I got to know.
Unlike other HIV patients I have interacted with who have not yet accepted their hypertensive status, Charity's mindset and approach to the condition was mind-blowing. She has been able to manage the hypertension for the past 8 years. She tells me how she effortlessly manages both medical conditions.
I would say I have gone through the bigger side of my health cycle, the health challenges, the trauma side. HIV, I would say that when they mention to you you are HIV positive, it's a whole headache. So once I have been able to go through that challenge, when I was told I'm hypertensive, I said, oh, I've even managed to overcome HIV. How much more hypertensive? The main thing is the same as managing HIV. You have to adhere to your treatment. You have to check what you are taking and all that. The only thing is with HIV, you don't stop eating so many things. But with hypertension, you have to check your diet and all that.
As a person living with HIV and now hypertensive, Charity also Danson has broadened her knowledge base on the new condition, which then informed her dietary choices.
I personally, I try to like my milk intake, I reduce it, my sugar intake, I reduce it, my meat intake, I reduce them, and I take more of vegetables and then fish, dry fish especially. And recently, I've started adding dawa to my meal, and I'm really enjoying it. A lot of dawa and a lot of green to my diet, and I'm really enjoying it. Yeah. So it's like nobody has told me, but I'm trying to do it myself.
Surviving through pills for the greater part of her adult life has been challenging. Charity says she has no option but to continually take her pills to enable her to live longer. She mentioned some discomforting symptoms since she became hypertensive.
I get tired very often. my heart normally beats early, especially when I finish menstruation. It's like, I would say at that time my blood has then reduced, and I need to feel the blood, and then the heart needs to also get what it wants to support the body. So when I walk from here to a little distance, I get tired. Like when we were going there, I just finished my message. So when we were moving to there, you saw that you were leaving me behind. So that is how it is. So sometimes if it happened that way, I have to stop small. Though I'm taking my hypertension medication, the Nifecard and other things, but I'm managing it small.
Though some of the drugs for the treatment of hypertension are covered by the National Health Insurance Scheme, the most expensive ones are not. This, to her, is a major challenge to persons living with HIV, as it represents a stressful financial toll.
With HIV, we are being supported with our antiretrovirals and other medication, even though it's not all, our labs are not covered. But with hypertension, nobody is supporting them. And that is one major challenge. And even sometimes, some of them, taking the medication itself, you have to eat something. It's not everyone who gets that, let's say, the 3 meal square before taking those medications.
It is estimated that about 24% of persons living with HIV are hypertensive, giving a total of nearly 8.9 million persons living with HIV who are affected globally. Even though these estimates vary substantially across countries, Ghana is yet to conclude on the number of hypertensive persons living with HIV. According to the National AIDS Control Program, prevalence of hypertension in HIV patients are increasing due to the aging HIV community, but Ghana is yet to know the total figures countrywide.
We are now yet to undertake, let's say, a big study, of hypertensives in HIV. But I can say to a very large extent that it's quite prevalent because of the aging cohort of patients living with HIV. Since we started treatment from 2003, we've had people who have lived because of antiretroviral medication. So there are some people who have been on it for 15 years, for 20 years, now getting there. But we introduced treatment in 2003. So people have grown.
Though hypertension is often attributed to the aged, young persons are also getting infected in recent times. Dr. Eziado outlined some major causes of hypertension in persons living with HIV.
Apart from the medicine side effects, one of the effects generally of recovery is that, and when they take the medicine, they get hungry. To take the medicine, you need to relate it to meals you eat. Somebody who was immunosuppressed has lost appetite, is anorexic, and now that they are recovering, they tend to eat a lot and eat more. It's similar with fertility. Some of the females, they have suppressed fertility because of the virus. When they are getting better, now they become very fertile. Some of them got twins and all that. It's a kind of a recovery thing, like the body is now bouncing back. So in the same way also, people in recovery eat, appetite gets better, they overeat, and they become overweight and obese. And obesity is one of the independent factors associated with hypertension development. We know that there is a lot of psychosocial stress associated with people living with HIV. And stress in itself is an independent factor for hypertension development and diabetes. The other issue could be also general damage, once there are immunity issues and there are issues to do with functioning of organs and all that, that could have a general effect also. So these all require further studies.
The National AIDS Control Program, NACP, agrees that not much attention has been given to this new trend in persons living with HIV due to the overall focus on reducing HIV itself.
To a very large extent, that is one of the reasons, that one of the new areas that we are looking at. In the past, it didn't used to be a priority. So we want to begin to look at the surveillance of these non-communicable diseases amongst our aging population. About 350,000 people are living with HIV, and just 8% are children. So the rest are adults, about 15. But if you take 60, 40 years and above, there are quite a significant number of them. So we know that gradually, as our epidemic is maturing, there will be people who will be coming down with hypertension.
NACP is collaborating with the Public Health Division of the Ghana Health Service and Non-Communicable Diseases Unit to introduce an intervention known as differentiated care for hypertensive persons who are also HIV patients.
The only intervention is differentiated care. The differentiated care isolates the people who need hypertensive care as part of HIV. But to be able to do that very effectively, it's a whole health system issue. And because of that, we are collaborating with the other departments and other programs within the Public Health Division to do this. We can't do it alone.
We are reviewing the HIV care plan. And what that means is it drafts the number of services that will be provided for persons living with HIV, and screening for hypertension, screening for diabetes, and screening for cervical cancers have been included. What it means is that once a person comes to a health facility and they are HIV positive and they are coming for their routine care, they would automatically be tested for these other conditions in order to find out if they have the conditions at all. So if it becomes routine, then it means all health providers who are attending to these persons will deliver the service.
According to the Non-Communicable Diseases Control Program of the Ghana Health Service, hypertension prevalence is surging. An average of 600,000 cases are recorded in a year nationwide. The acting program manager, Dr. Efua Kome, hinted of a general demographic shift on non-infectious diseases across the country, and these include the HIV community.
Unfortunately, we don't have a national prevalence data or information for persons living with HIV. The challenge being that it is not all the HIV clinics that run NCD clinics. So that is the strategy that we are employing now to ensure that once a person has come for the HIV clinic or they're coming for their medications, we can expand the services to test for hypertension, to test for diabetes, and even to screen for cervical cancers. For the HIV patients, any other we call them comorbidities, or any additional condition that has an effect on, let's say, their immune system is going to further bring their system down. So even the way they respond to their drugs, they are going to get much sicker if they are not taken care of. And it's important that the health system is able to recognize these conditions early, pick and then control the condition so that it doesn't interfere with the progression of their disease. So it's very important. And even beyond HIV, generally, as the population is aging, as we are growing, certain conditions are coming up, and it's reflected in the population with HIV as well. So the much older age groups would have more of these non-communicable diseases, including hypertension, diabetes.
The NCD says most non-communicable diseases, especially hypertension, is underreported, hence the need to sensitize the public on its dangers.
For the HIV clients, because they regularly have contact with the health system, they need to come in for their review of their medication. They need to come in for a review of their conditions as well. It gives a huge opportunity for health workers to at least find out or be inquisitive as to whether other conditions are present and to look at their records. But there are some people who don't come regularly. So they stay in the home for like 3 months up to 6 months because they are stable and they are on medications already. They do their own refills at home. Until the 6 months is up, they are not going to come to the health facility if they don't have an issue. So for these persons, they might not actually be conscious about, I mean, it's HIV that I'm treating for. Where is this hypertension from? You might not bring your mind to it. That's how come it's important that we build a lot of awareness and create a lot of sensitization around these non-communicable diseases.
There's been some level of complacency as far as all the chronic diseases, hypertension on its own, and diabetes is concerned, because it's very old. People are used to it. But if you really check the top 5 causes of death in our country, it's from these conditions: hypertension and associated, complications like stroke, CVA, and all that. So that maybe has contributed to the attitude. People think it's routine, it's normal. In fact, some people feel that, this is age-related, we should just handle it like that. Okay. But it didn't, for HIV, it was not a priority, because for most people who were getting HIV, they were within 15 to 49. Okay, so, but now we're having people crossing the 49s, going to 50 and 65, because we've come a long way.
One would wonder how persons living with HIV are managing the psychological effects of surviving on pills. According to a majority of persons living with HIV, taking medication on HIV and hypertension can be tiring. Fatigue is common among people with these conditions. There are a range of medical and day-to-day factors which can cause fatigue. Health experts say, though the daily routine of taking medicines is stressful, it must not be pushed aside. The NACP and the Ghana Health Service, together with its partner agencies, are working around the clock in getting a one-time medicine to ease the burden on persons living with HIV.
The person who is taking the antihypertensive, usually they will take like 2 to 3, morning and evening, and all that. You're going to add it to HIV. Taking the medication in relation to HIV medicine will be a challenge we need to look at. HIV, we are planning to introduce a long-term injection now, so that people will get the jab. You come 3 months, or let's say 1 month, before you get another one. So then that takes away swallowing. And then if you are even hypertensive, you can swallow your medication. I'm hoping that the non-communicable disease will be looking at improved medications where there will be fixed dose combinations, so that people can take, and it simplifies the disease, the pill burden.
People are hardly able to complete a course of antibiotics that you're only taking for 5 days. How much more taking the medicine every single day of your life? So it is very stressful psychologically, but then you also look at the other side. If you don't take the medicines, what happens? Developing complications are so bad that if you're not careful, it threatens your very life. Meanwhile, people have been on the medications for over 4 decades, 40, 45 years, and they are still very healthy. If they don't tell you that they have hypertension, you would never know, because they've been very consistent.
Health experts say plans are far advanced in reviewing the HIV care plan to cater for both health workers providing HIV services and persons living with HIV. Experts are advocating for all health workers across the country to undergo training to enable them to provide hypertension screening and other non-communicable diseases at their various facilities.
Within the context of shared confidentiality, the other service provider must have the capacity to be able to protect the privacy. But we know that the persons living with HIV are not comfortable. So it's the reason why now we want to be able to take care of the person in the ART clinic. Like you come and you need diabetes care or something, you should get your care within. But that requires a lot of training and collaboration with the general health system, because the other issue is convenience and where the commodities are, the structure of the service. It said that if, for instance, in Kolebu, there is a diabetes clinic, okay, there's a hypertension clinic, so How do you make sure that now you have to build the capacity of people in diabetes clinic to be able to take care of HIV? And that is what we have to do going forward. But this was catered for by default when we were scaling up antiretroviral therapy.
In treating or managing hypertension, healthy eating plan is key. In my interaction with a dietitian at the Trust Hospital, Mr. Wise-Lecha, excessive intake of fried foods, alcohol, salt, and many others are the contributory factors for the increasing number of hypertension cases.
HIV makes the immune system very active, and that may cause inflammation in the blood vessels. So that is what leads to the development of hypertension a lot of the time in HIV patients. That's why the statistics are that bad. Yes, so you have to focus on managing the condition so that the level of engagement that the virus will have with your immune system will be reduced, and that will also cut down the risk of having high blood pressure. So focus must be on getting tested, people who haven't been tested, and you know your status, then you follow your medical therapy.
Mr. Lecha touched on the various processes an HIV patient who is hypertensive will undergo before a healthy eating plan can be prepared for them.
We will do our own assessment, find out about the person's dietary habits, or we call it a diet history, which is very, very important. So we find out what the person is taking or the patient is taking. And then beyond that, there are other forms of assessments. We'll do anthropometrics, check the weight, height, and do other body measurement to see whether the body is growing well or has grown well, or they have the right body for their height or age and all that. And so we put all this together. There are other aspects like the kind of medications they are taking and all that. So we put all this together and then put together a healthy eating plan.
He implored HIV patients to eat recommended diet since it has a tendency of boosting their immune system. Mr. Wise-Lecha indicated that though good nutrition has a lot to offer persons living with HIV, it cannot be an alternative to antiretroviral medicines.
Good nutrition has a lot to offer in terms of helping an HIV-infected person enjoy a high quality of life. Yes, but then it cannot be used as a substitute for any form of therapy, other drug therapies like ARTs and co. They have their role to play, but good nutrition sets the tone for even those medications to do their work well. So it has to be a synergy, a combination of the two methods. Eat well, exercise, take your medications, and then nobody even will see you and ever think that you have the condition.
Currently, there is a dietary and nutritional care for persons living with HIV to manage hypertension at all levels within the HIV community. This nutritional care is under the supportive care of persons living with HIV.
Nutrition plays a role in even managing a person's immunity and all that. The kind of foods that you eat and all that can support your body to resist infection. So even your medication intake, there are related interactions. There are some kinds of foods that when you take and you are taking your medications, it can affect it. So once the element of hypertension comes in, issues of obesity comes in, it must be managed. And as part of the supportive care for persons living with HIV now, nutritional care is very important now to be able to curtail hypertension.
Aspects like salt will have to be watched closely, not too much, and also it's not like no salt. And then there shouldn't be so much oil also, like you cut down on the amount of oil, the amount of frying, the amount of vended food that that person will have to eat. And there should be a lot of vegetables which will also boost the immunity of the patient, and also fruits which will release all the vitamins that are necessary for building the body up, and then other minerals like iron, like potassium, like magnesium, and all these things can help in the way the heart muscles work.
There are calls on improving weight management program and services in the country as it is currently low. Experts reveal that a lot of people have not subscribed to any weight management program.
We need to improve weight management services in our country. Already, even in the general population, a lot of people are not subscribing to weight management programs. Okay, so when you have diabetes, you go to diabetes center or hypertension, they will tell you, okay, don't take this, take small this. But, people cut back and it doesn't translate very much in an effective weight management program. We need that.
On top of the list will also be the patient's exercise habits. Exercise does a lot of things, helps control weight, control blood pressure, blood sugar, and co. And so in this context, some level of exercise is even necessary for strength, so that the muscles and bone structure of these patients will be very good and function at peak levels.
The public, especially persons living with HIV, are being cautioned to undertake routine checkups to know their hypertension status, as badly managed blood pressure can cause many diseases like kidney failure, heart diseases, and even stroke.
There are some people who have actually been told that they are already hypertensive. Even for persons living with HIV, there are some who know their status with respect to hypertension and diabetes. For those persons, it's important that we encourage them to continue taking their medications, because already they are on the antiretroviral drugs, and then now they have to start taking medicines for hypertension and diabetes. And that sometimes presents a lot of challenges because their medicines are a lot. But it's important that these medicines are taken to have a good control on the blood pressure so that it doesn't get out of hand. It is really sad when somebody can end up developing a stroke while their HIV is well controlled because their blood pressure was not under control. So as we continue educating clients, we need to also encourage them to take their medicines regularly and to regularly come for their reviews.
Hypertensives also, with time, people promise them cure. They also want to survive. They leave their medications and they go to herbalists and other places. And unfortunately, some of them come down with the complications of stroke and all that. So dealing with that and HIV is a double jeopardy.
One would ask, if hypertension is non-communicable, why should one pay attention to it when it comes to persons living with HIV?
The HIV itself is chronic. It's like a lifelong condition, even though they acquired it through an infectious means. However, as they are growing older, they also have the potential of developing the non-infectious diseases. It's just like having malaria and then developing something like a diarrhea as well. The malaria does not stop you from developing the other. In the same vein, if somebody has an HIV, they could develop diabetes, they could develop hypertension, they could have a cancer. But having a good grip on the HIV means that you should also have a good grip on the chronic disease, because the chronic disease is going to affect all their organs as well, and it's going to further bring down their immunity such that they are going to get much sicker, in quotes. So it's important you get a good control of their non-communicable diseases so that their well-being will generally be improved.
Over the years, hypertension have claimed many lives, including persons living with HIV, but sensitization on the disease is on the low as compared to other chronic diseases.
Generally, awareness is key. Awareness, even amongst health workers who are taking care of these clients, tends to be low for non-communicable diseases. So in the same vein, health workers who are taking care of HIV clients, it is likely that their awareness on non-communicable disease will also be low. When people are aware, they tend to ask questions and they want to seek more service. So it's important that we keep on educating people that once you are growing old, hey, you are likely to develop some disease. So go and screen. Go to the health facility, ask them that, oh, I'm this age, I've never done a screening before, I want to screen. They will take you through, they will test your blood sugar, they will test your blood pressure, just to be sure of where you are.
So HIV on its own is a whole kettle of fish. It's a whole big thing, and we have to look at. So the focus has been on that centrally. But the care of a person living with HIV also includes taking care of other needs. So that's why we have to do a baseline screening for them before we put them on medication. And part of the baseline assessment is taking BP and all that. Because of the potential side effects, we also first of all want to see what your baseline levels are with respect to sugar, your BP, even your liver function and all that, your kidney function, before we put you, because there are some medications that have an effect on the kidneys.
The issue of stigma is still a major challenge, not only among persons living with HIV, but also among health workers taking care of persons living with HIV. The NACP says this and many others are serious challenges which need to be looked at.
You know that the stigma of the person living with HIV has also affected the stigma for the service providers. We saw a phase in our response where health workers, doctors, were all moving away from ART care. They were not, because you see, it takes a lot more effort. When a client comes HIV positive, you need to counsel the person, provide support. You spend more time compared to other people, compared to malaria, so it was not easy. And some of them burnt out and all that, the nurse similar, the same. Now, to imagine that you are going to take care of HIV, which is a chronic disease, and also another person who has hypertension, a chronic disease and all that, immediately it introduces a double jeopardy. This is very difficult. We anticipate that these will be some of the challenges.
There is a word of advice for all.
For me, I think more of education has to come up. And then I will also encourage my peers, my people living with HIV, my colleagues, to put away the stigma. And no, it's not easy. Stigma from the community, stigma from the facility, stigma from family. I know it's not easy, but we should not be self-centered. We should not think of ourselves alone. We should rather think of others.
HIV is still real and is going to remain with us for some time. The persons living with HIV are surviving because of antiretroviral therapy, improved knowledge and care. They should pay attention to their nutrition. They should involve themselves in exercise, which is measurable. They should adopt healthful, dietary habits, avoid, the substances of abuse and alcoholism and all that, and to make sure that at least they have the right size for their heights to minimize non-communicable diseases so that they can survive longer and fulfill their destinies and contribute to the development of our country.
We have a huge opportunity to ensure that we're able to counsel our clients well, educate them on what to eat, live healthy, and then also to screen them for hypertension. And if we pick up a high blood pressure, we'll be able to manage them appropriately. And for the persons living with HIV too, it's important that they understand that the fact that you have HIV does not mean you cannot get another condition. And if you get that condition, kindly take all your medicines and talk to your health provider about it.
The mere fact that you have the virus which is causing a sickness, you are predisposed to having high blood pressure. So to be able to deal with this menace, we must stop the infections. HIV is still real, still out there, so let's protect ourselves.
Hypertension is highly prevalent among HIV-infected patients, especially those on antiretroviral treatment. There is therefore the need to integrate hypertension screening, diagnosis, and treatment into routine HIV care to prevent disease-related effects and improve the health of people living with the condition. Health experts say hypertension will continue to remain a silent killer and public health threat to persons living with HIV if not captured under the National Health Insurance Scheme or treated for free. As concerns about the management of hypertension among people living with HIV grows, adequate infrastructure must be built for the provision of antiretroviral therapy. Other care services must be leveraged and adapted to respond to the growing burden of hospitalization among HIV hypertensive patients. Agencies mandated to embark upon public health campaigns must be well resourced to conduct more advocacy programs. Beatrice Senadju, GBC News, Accra.